Hello, everyone, and welcome to this video on Toronto Notes for QE1 candidates. I'm creating this series to help QE1 candidates review the Toronto Notes page by page. I hope it's memorable and easy to assimilate and, just easy to walk through the Toronto notes while you're doing other things, driving, cooking, and just is a reliable companion for you. So today's video is on prostate cancer screening, and we'll get through this very fast. As a reminder, we're currently this playlist covers family medicine topics, including periodic health exam and health promotion and counseling. So we hope to work through all these topics for family medicine. A clinical scenario to start us up. A healthy 60-year-old man comes for a routine checkup. He has no urinary symptoms, no significant risk factors. He's just heard about a friend's prostate cancer diagnosis and he wants a PSA test. As the family physician, should you offer him a PSA test to screen him today? So while you think about that, I want you to learn the guidelines. So the guidelines want you to categorize patients into three age groups. For men that are 55 years and younger than that, you don't need to do routine PSA screening. The guidelines are don't screen. No. But for men that are 55 to 69 years, the guidelines say do not routinely screen. But with this group of patients, you can discuss the risks and benefits and consider their preferences because the evidence is that the benefits you get from testing this age group is very small and the arms of these tests may be significant. But for patients who are in the age group 70 years and above, it's also very clear do not screen. So for all three groups, age groups, do not screen. But specifically for 55 to 69 years, you have a chance to talk about these with your patient to identify what risks and benefits there may be in conducting this test. All right. So why don't you screen everyone? What does the evidence say? The research shows that there is very small reduction in mortality from prostate cancer by screening everyone. And the potential harms which you need to educate many of the patients on is when there are false positive results, it results in unnecessary biopsies, over diagnosis, over treatment. And with the biopsy and all of that, you can begin to see risks such as urinary incontinence, erectile dysfunction. And these symptoms may last a patient's lifetime. So it's more advisable to avoid these significant complications by not screening everyone with the PSA test. So that's really important to communicate when we are having the conversations with patients. Now, the QE1 pearls to remember. First, routine PSA screening is generally not recommended, whether whatever age group the patient is in. But for age group with 55 to 69 years, that's the age group you need to do some shared decision making and discuss the risks and benefits. The benefits very minimal, but the risks, there's so many risks that we've identified on the previous page. So you must remember to share that with your patient. Um, Overdiagnosis and overtreatment, they're the major arms. Shared decision making is often tested on the exam. So you'd find questions that say do not screen, an option in the question that says do not screen, and maybe another option that wants you to explore the conversation about risks and benefits with your patients, and that would be the more advisable um, answer to pick. All right. Um, so here is a practice question for you. I want you to pause the video and choose your best answer. 72-year-old asymptomatic man comes for annual examination. He wants a PSA screening. What do you do? What's the correct answer here? Well, so the correct answer is C, recommend against PSA screening. Um, and patients that are this age group should not have routine PSA screening. There's no mortality benefits, and there are arms and downstream complications that are significant. So, um, that's it on prostate cancer screening. Very straightforward, and you shouldn't miss it in the exams.